Hi, everybody. Uh, First of all, thank my wife actually for setting everything up so that I could record for you because this was an interesting ECG. So see if I can get this out of the way. Just hope it doesn't start. Okay, let me just minimize this slightly. Okay. Yeah, so this was an interesting ECG that came through from our doctors, Matubela and Suji at Danhausen. They were a bit worried about this patient who came in at the age of 23, was presenting with severe centralized chest pain and hypertension. So even before we get to the ECG itself, I really need to think about, what are we looking at, Let me just try and get my spotlight on here so you guys can see. Okay, I hope you can see that a bit better. So even if we haven't seen the ECG, or just got a 23-year-old, let's say you're walking from your car in, you've been called by one of the nursing staff. As I always tell you, you've got to start formulating hypotheses in your mind already. So when it comes to chest pain, young people, first of all, cardiac is actually not at the top of your list. You would start thinking of trauma. You start thinking of lungs, so pulmonology. You would think even of the GI tract, even though it's centralized chest pain. And I think cardiac would probably come forth simply because, your cardiac manifestations in young people are much rarer than the others, So in any case, cardiac has to be there. So let's say you go, this patient has no cough, no shortness of breath, no evidence of respiratory. That's fine. No reflux, nothing like that. There's no history of trauma, as was the case in this patient. And you find a very high BP. In this patient, it was 180 over 110. So your mind starts going towards cardiac. Now you've got to start thinking to yourself, if it is cardiac, what are the possibilities in a young person with centralized chest pain? Now, you must remember, we don't have much else. So we assume this patient was apyrexia. We can assume this patient was distressed because of the high heart rate and the high BPs, which may have been due to pain as well. So you've got to say, okay, what are my differentials? And as soon as you do that, you immediately cut it down. So it's either ischemia, infection, inflammation, tumor. You could probably add valvular disease, but it's very uncommon in a 23-year-old. So you would first look for ischemia, inflammation, and infection. And inflammation and infection can sometimes go hand in hand. So let's have a look at this patient. Let's analyze this ECG. So when we look at leads 1 and leads AVF, we see that it's a normal axis, but we can see there's left ventricular hypertrophy, that's for sure. All right, so there is LVH. Now, the thing is, this is most likely an acute LVH. Why do I say this? Because this patient hasn't presented with cardiac issues before. So when we say LVH, now what we are talking about is the amount of current that's passing through the left ventricle. So as you can see, it's a large amount of current. Now, there's few reasons for a large amount of current to pass through. Number one, the right side is so damaged that there's nowhere else for the current to go, so it goes to the left-hand side. Now, that's not the case here. The left-hand side has grown so large that it, needs that current all the time. And then you have the situation where in an acute setting, the physiological demand of the left ventricle becomes so high that it demands all of that current in any case. Okay, so in this case, I would go for the third one, where we've got an acute left ventricular response, and we are looking at left ventricular hypertrophy based on that. Okay, so we would normally say look at lead AVL and lead 3. And you normally say lead AVR would be quite high and lead 3 would be quite low. It's a complete opposite. So in this patient, even though we're saying LVH, according to my own rules that I've given you guys before, even looking at it, well, you could say lead 1 also maybe, but in any case, we'll just skip that for now. Now let's look at our rhythm strip. All right. So what we've got is these nice peaked T waves. Oh, and of course, the other one I forgot to mention was pulmonary embolus. All right, so you are looking for pulmonary embolus. That was the other thing. So we've got peak T waves, which would tell us that there is some atrial struggle as well, right? Now let's see if we can get a closer look at this T wave. This P wave. I just want to see if there's a way for me to. Unfortunately, this is not done on Zoom. This is actually being done. Right, there we go. Okay, so I hope you guys can see that. So if we look at this period, so remember the first half is the right atrium, and then the second half is actually the left atrium. So if we look at this, we can actually see the left atrium is actually just struggling a little bit. It's pushing a bit harder. The reason I say that is because your right atrium kind of takes off nicely, but then your left atrium has this little bulge in some of them. So it just shows. Now, atrial physiology is not something that's very important in the emergency department. I'm just pointing it out just so that you could see. But if you were to say this was normal but peak morphology, nobody would argue with you. Now, there's one other thing to notice, and you can start seeing it here, is that if you look at the PR segments over here, I think let's just get a closer. Sorry. Sorry about this. Like I say, I'm not used to. Yeah, okay, I think I'm getting the hang of it now. So if we look at these if we look at these PR segments and compare them to the, let me just see if I can draw all this. All right. So this is the isoelectric line. All right. So in other words, the baseline. Okay, it's not allowing me to draw on this, unfortunately. But let's just have a look at it with the spotlight that I created. So if we look at this isoelectric line, we can actually see that when it passes through the PR complex or the PR segment, your PR segment is actually below. So that's an important clue. All right. So we've got a depressed PR segment. And we've got what you call it. Let's see if it's a shortened PR interval. We've got 1, 2, 3.5, so normal PR interval. We've got narrow QRS complexes. We've got a QRS after every P, and we've got a regular groupings. And it's quite fast. It's about 120 beats per minute. I think it shows it here at the top is about 119. So we've got a sinus tachycardia, which is also a sign of a pulmonary embolus. So let's go searching, because a pulmonary embolus should be at the top of your list now, thinking of cardiac. All right. So what are the signs? So the first thing we need is a right axis to extreme right axis, which we don't have. Okay. The next thing that we're looking at possibly is, and remember, these are all the minor signs, and then we're going to look for the main sign. Right. Now, in practice, what I normally do is when I suspect it, then remember that we go for the anteroceptal leads and the inferior leads, and we look for T-wave inversion, right? And if you have T-wave inversion in your anteroceptal leads, so V1, V2, V3, V4, and 2, 3, and AVF, remember, if you have symptoms and signs of pulmonary embolus, and then you have T-wave inversion here, then there's a 95% chance that it is a pulmonary embolus. But we can see we don't have that. We don't have a right bundle branch block. We've got the peak P waves, that's about it. We don't have an S1, we have a Q3, but no T3. We don't have right bundle branch blocks. So we have a lot of things that are pushing away from pulmonary embolus. So what could the next thing be? Ischemia. Well, let's go zone by zone and see if we have ischemia. So if we look at leads 2, 3, and AVF, I think you could argue that there's a slight ST elevation. So there's a possibility of ischemia. Okay. If we were to look at AVR, you'll see a slight, well, I wouldn't even call it a depression, a slight downward slope. If we come to leads V1 and V2, you could argue there's a little, well, it's not really an incomplete, but in any case, it might be a right bundle branch block, but it doesn't, actually scratch that. There's no right bundle branch block over here. So if you look at V1 and if we look at V2, you could argue there's a slight ST depression, but I doubt it. But interesting part is when we come to V1, V3, V4, V5, then you could argue that there's maybe these ST elevations that are slight, very slight, but definitely there. And then when you come to V6, you see a slight ST depression, but it's only on a single one. And of course, 1 and AVL not recording too well, so it doesn't tell us much. Now, the question is this ischemia? And the possibility is there because you do have this one area of ST depression that could be a reciprocal change from these, all right? The one thing that takes us away from that is this PR depression that we see, right? And this PR depression is widespread. The second thing that takes us away from ischemia is that the ST elevations, although minor, are also widespread. So what are the possibilities for that? Why would you get what you call it, such a large ST elevation signals? Number one is a widespread ischemia. All right, so that would be the first one. So it is a possibility. Number two would be ventricular aneurysm. Now, remember, ventricular aneurysm is normally associated with elderly patients and those who have had infarcts before. You would be looking for Q waves, you'd be looking for evidence of previous ischemia. So it's very unlikely. And then the third one, pericarditis. All right. So we've got to look for signs of pericarditis. And what are signs of pericarditis? Number one, clinical. Right. So clinically, patient is in pain. When the patient leans forward, the pain is worse. When the patient leans back, the pain feels better. Is there a pericardial rub? And then we look at the age of the patient. He's 23. He's got high BPs. We don't know if he's pyrexia or when, but we assume that he was apyrexia. The one thing that pushes me towards it is also, if you look, even though we don't have very good, okay, I suppose you can't see it too well here, but we'll try and get it. So here we have this P wave, all right, in the AVR, and this is one that I always look at. And if you look at this PR7, which is a very tiny segment over here, you can see it's above the isoelectric line, even though it's ever so slight, but it is above the isoelectric line. And if you start looking at our P waves and our PR intervals, wherever we have them, you start to notice, for example, let's have a look here in V3. Now, I know it's not very clear, but I hope you can see all of these PR segments are all depressed. Right? So this tells us this is either an acute viral, but more likely an acute bacterial pericarditis, which fits age, which fits clinically, and fits with what we would expect from such a patient. Now, the question becomes, okay, can we definitely say it's not ischemia? No, we cannot definitely say it's not ischemia. We have to assume that the patient may still have ischemia. So we do have to do our enzymes. We do have to make sure everything is okay. But there's enough here to say that this could be an acute pericarditis. Why is the patient hypertensive? Like I said, there's an acute left ventricular reaction. So what's happening is you've got this pericarditis, let's just say, that's sitting around the heart and most likely around the left ventricle looking at this. And what it's doing is, number one, it's causing irritation and pain. So that's causing the patient to have a normal physiological reaction, like getting shot in the arm. So what happens is that you start getting these sinus tachycardias and you start getting a hypertrophic pattern. Okay. So this is starting to lead more and more towards the conclusion that this may even be slightly constrictive. So if there's a slight constrictive element to it, then the left ventricle is trying to expand, but is unable to completely. So it starts beating much harder. Now, I was asked a very interesting question by one of our doctors. Why could it be myocarditis? And I'm actually going to get into that just now. And there's also always a possibility of what you call myopericarditis in all of these patients, but we'll discuss that in a second. So in this patient, it turns out to be more of a pericarditis picture, and the patient was transferred. So the patient responded to steroids for the simple reason that pericarditis, regardless of the cause, autoimmune, bacterial, mycobacterial, viral, whatever it may be, is an inflammation. So if you treat the inflammation with steroids, you start seeing a difference. In this case, the patient was given morphine, steroids, antibiotics to try and ease up whatever it may be. Showed improvement and was transferred for further management, echoes and things like that. All right. Now, I'm not 100% sure, but if I remember correctly, Dr. Suji also told me that the BP normalized and every patient became stable. He told me the patient was stable, so I assumed that the BPs came down to normal once that was done. All right. So this is a pericarditis. And this is a common picture that you will see. And what I've noticed over the last few weeks, having been stuck at home and receiving ECGs from people all over, which I appreciate, it's really good. The one thing that struck me is that a lot of you guys are scared. You see something, and unless the answer immediately jumps out at you, you're scared that you don't know what's going on. So remember, and I'm going to tell you this again, there's a lot of times when even I look at ECGs and I just go, oh, wow, what the heck is going on here? So what you've got to do is break it down into its components. Axis, rhythm, rate, zone. And once you start doing that, then you start seeing things. Now, let's say you had said this is an ischemia. Let's say you didn't pick it up as a pericarditis, but it's very mild signs. I mean, very subtle signs of pericarditis. But let's say you said ischemia, but you have enough to go on to transfer the patient. And if somebody senior says, no, this is just pericarditis, that's fine. That has nothing to do with you. But the fact remains that you broke it down to what it was. The worst thing you could do for this patient is send him home because he's going to die. It was a male patient. Sorry, I'm not trying to be sexist. It was a male patient. So that's how you've got to think of it, all right? Break it down into its little components. And even if you can't reach a final diagnosis, you can at least say, okay, this is wrong, that is wrong, that is wrong. Let's take it from there. Okay. All right. So what I want to do now actually is that I want to just talk a bit about myocarditis, simply because it came in into the conversation with one of the doctors. So I didn't have anything in particular on myocarditis on my side. So let me just take this. Also, I can use my mouse. So these are the ECG changes that are normally seen in myocarditis. So you get sinus tachycardia, non-specific ST segment and T wave change. So it's completely non-specific. But the general presentation is of fever and arrhythmias. All right. Even though these are common, you do tend to get arrhythmias. Okay. The reason being, and what I want each of you to do is imagine your bicep, right? Now I want you to move your bicep up and down, up and down, up and down, which you can do. All right. Now I want you to imagine that your bicep is inflamed. All right. Now, your bicep is inflamed for whatever reason, be it viral, be it an abscess, be it whatever it may be that's causing it over there. What do you think is going to happen to this rhythm that you are doing with your ECG? Number one, it's going to be a bit difficult for you to actually keep on doing it at that pace. So you're going to start slowing down. Or speed up at first, but eventually you're going to start slowing down. What's going to happen is that you're going to start feeling pain. So you're going to mimic exactly what a pericarditis gives you. You get tachycardia, you're going to get pain, but the chances of you having a higher BP are less. The reason being you're unable to contract at the same force simply because there's something over there. So most of these patients now clinically tend to come in with lower BPs, signs of cardiogenic failure, and then of course, centralized chest pain. And because it's most commonly bacterial, viral, they often have quite severe fevers. And remember, you're talking about the main part of the heart. Everything that we do with the heart is to preserve the myocardium. So once the myocardium is involved, you start seeing rapid deterioration. Okay. So these are some of the ECG changes: prolonged QRS, QT prolongation, diffuse T wave inversion, which are all very what you call non-specific. Once you see an arrhythmia, any arrhythmia, and I've seen premature ventricular contractions, so and AV conduction defects, like I say. So once you start getting this arrhythmia and you start getting mixed, sometimes you may even get sick sinus syndrome, which is tachycardia followed by bradycardia, which I hope we'll talk about one of the days. Then, and of course, you can get an adjacent pericarditis, so the picture can be mixed. Now, but remember, no matter which it is, pericarditis, myocarditis, your patient's going to cardiac high care. So it doesn't make a difference if at your level you can't differentiate, but if you can, that's great. Right? So what is it? Myocardial inflammation, the absence of ischemia, often associated with pericarditis, usually a benign disease if treated properly. All right. In the acute setting, now this is what I'm talking about: your bicep moving up and down, arrhythmias, failure because it can't keep on moving, cardiogenic shock. Okay. In later on, delayed cardiomyopathy. So the most common: viral, bacterial. You can have immune mediated, and this is also important: drugs and toxins. And I would put amphetamines quite high. So those of you from who followed Breaking Bad, you know exactly what an amphetamine is, and you know the effects that it has on the body. All right, clozapine not as commonly used, but amphetamines very widely used these days. So here are some ECG examples. So here we just see sinus tachycardia. We don't see much else. We don't see, we can barely make out our P waves. We can see a bit of QT prolongation. but it's not exaggerated. We can just make out the sign is tachycardia. And there's not much to go on here, okay? And here, if we go, it's with widespread ST elevation, all right? And these are signs of pericarditis actually in this patient. So if we had to go in a little bit closer, we might see these PR depressions like what I've been telling you. Not as prominent, but you can see them, all right? So you can see that PR segment going down. So pericarditis, okay? So if you want to do some advanced reading, you can take a screenshot of that, okay? All right, so let's just go back to our ECG. And yeah, so I hope you guys enjoy that, and I hope it makes sense, and I hope you guys learn something. So unfortunately, we won't be releasing another video this week. The ones that got corrupted, we're almost done trying to salvage some of them, and it looks like 2 of them may well be okay. So in the interim, if I find interesting stuff, if you guys send me interesting stuff, I'll try and do things like this. Okay, but keep well and enjoy yourselves. And I hope I can send you all something soon. Send you all something to learn soon. Okay. Goodbye, everybody.